Animation. So your name is Keshav, right?
Yes, sir. 3, 2, 1, start.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today we have a teaching class on surgical management of male infertility. This will be presented by our resident, Dr. Keshav Paliwal, and would be moderated by our faculty, Dr. R.D. Sahu. So I would request Keshav to kindly start his presentation. Yeah. Right.
Good morning, respected teachers. Today's seminar presented by me, management of male infertility, moderator Dr. R.D. Sahu sir, and I'm Dr. Keshav Paliwal. Male accessory gland infections and infertility. Infections in the genitourinary tract may play a contributing role in up to 15% of male infertility. Leukocytospermia is a well-known indicator of infection or inflammation in the male sex gland and the urogenital tract. Potential curable cause of this is the potentially curable cause of male infertility. How to diagnose a MAGI? A direct counting of round cells in semen is highly inaccurate due to the presence of immature germ cell. Immunocytochemical staining is the gold standard, and peroxidase staining is the best alternative for diagnosis. There is a less than 10 to the power 6 per ml leukocytospermia is physiological, and semen cultures are unreliable due to antibiotic property of zinc. Presence of more than 10 to the power 6 leukocytes per ml in human ejaculate reflects the presence of genital tract infections. Studies have demonstrated that leukocytospermia has negative impact on sperm function and integrity. A positive correlation between leukocytospermia and high sperm deformity index scores are ectosomal damage and midpiece defect and tail deformities are present. How to treat MAGI? Antibiotics, COX-2 inhibitor, antihistamines, antioxidants, and frequent ejaculation. The empirical therapy for male infertility is lifestyle changes, avoidance of heat exposure, toxin exposure, and stress. Smoking cessation, alcohol abstinence, anti-estrogens, antioxidants, and micronutrients. Antioxidants and micronutrients have associated with fertility is lutein, zinc, arginine, vitamin B12, free radical scavengers, lycopene, vitamin C, vitamin E, glutathione, selenium. Oligoasthenoteratospermia, if there is an increased FSH, then severe germ epithelial damage are present, and if there is anti-sperm antibodies, steroids can be given. In varicocele, varicocelectomy can be done, and in infections, antibiotics can be given. And in idiopathic cases of oligoasthenoteratospermia, empirical medical treatments can be given. In agiospermic patients, if there is a bilateral absence of VAS, CFTR panel of patient and the female partner should be done. And if there is no bilateral absence, VAS is palpable. If there is a semen volume is less than 1 ml, then sperm absent on post-ejaculatory analysis. If it is yes, then transrectal ultrasound to evaluate for ejaculatory duct obstruction can be done. And if there is no sperm, if there is a sperm present in the post-ejaculatory urine analysis, the retrograde ejaculation is present. In semen, if semen volume is less than 1 ml, and the longitudinal axis diameter is more than 4.6 centimeter, and FSH value is less than 7.6, then 96% cases have obstruction in the VAS, and In less than 4.6 centimeter in microtestis and FSH is more than 7.6, then it is a primary primary testicular failure. And in azoospermic patients, in obstructive cases, there is a normal FSH value and epididymis is enlarged and normal testis. Then exploration and check for vessel patency can be done and vasoepididymostomy can be planned. In equivocal cases, normal FSH value will be there and normal testis volume is there. In increased FSH, there is a and small testis, the primary testicular failure is present. There is invasive male infertility management and obstructive azoospermia. There will be normal FSH value and normal site testis with epididymal enlargement. There are many causes of obstruction. The intratesticular obstruction 15%. In 15% cases, the intratesticular obstruction are present in epididymis. 30 to mostly epididymal obstructions are present. 30 to 67%. The causes of epididymal obstructions are infections, trauma, post-surgical iatrogenic obstruction, congenital epididymal obstruction, other congenital forms of epididymal obstructions, and vas deferens are in vas deferens vasectomy, previous vasectomy, vasotomy or vasography with improper technique, post-surgical iatrogenic obstruction in scrotal surgery or herniorrhaphy, congenital unilateral or bilateral absence of the vas, in ejaculatory duct cyst will be there, Mullerian uticular prostatic or seminal vesicular infections, traumatic or post-surgical iatrogenic obstruction, and if nothing can be found, functional obstruction is there, idiopathic, acquired or local neurogenic dysfunction. Sperm retrieval techniques are known in non-obstructive azoospermia, testicular sperm aspiration, TESA, or if we are using microscope, then micro-TESI, microdissection, testicular sperm extraction. In obstructive azoospermia, microsurgical epididymal sperm aspiration and percutaneous epididymal sperm aspiration. Open testicular biopsy, testicular sperm microsurgical technique remains the gold standard and provides an optimal amount of tissue for the accurate diagnosis. The retrieval of sperm can be used for IVF. Indications of TESI is failure to find sperm in the epididymis in the presence of the spermatogenesis and complete absence of the epididymis, non-obstructive azoospermia. This is the photograph of open testicular biopsy. The slides can be directly made from the testis, and the dilated tubule are dissected out. The outcomes of TESI is in Klinefelter syndrome 68%, in azoospermic factor deletion and chromosome Y deletion in 70%, and like post chemotherapy in 53%, and cryptorchidism is 74%, maturation arrest 40%, and AZF A or AZF B, azoospermic factor A, azoospermic factor B deletion are this is a severe kind of deletion, and there is no sperm retrieval. Percutaneous testis biopsy is a blind procedure. Risk of unintentional injury to either the epididymis or the testicular artery should not be used when previous surgery. This is the gun, biopsy gun we use for prostate. The testicular biopsy can be done by the biopsy gun. Testicular sperm aspiration is the blind procedure. Immobilization of the testicle by grasping it with the epididymis and cord between fingers while pulling the scrotum skin taut. Performed with a 23 gauge needle or angiocate from superior pole of testis. Less invasive and less painful than percutaneous biopsy, yields few tubules with poorly preserved architecture, is significantly lower yields of sperm than open microsurgical TESI in men with non-obstructive azoospermia. This is the testicular sperm aspiration technique. Microsurgical epididymal sperm aspiration is an invasive procedure, provides retrieval of many sperm. Less epididymal damage can be cryopreserved and used for future procedures. Intraoperative sperm retrieval at the time of vasoepididymostomy or as an isolated procedure in men with congenital absence of the vas or unreconstructable obstructions. Through medium ref approach through two small transverse scrotal incision after delivery of the test, the tunica vaginalis is opened and the epididymis is inspected under operating microscope. The epididymal tunica is incised over a dilated tubule. A dilated tubule is isolated and incised. The fluid is touched to a slide and the fluid examined. If no sperm are obtained, the epididymal tubule and tunica are closed and an incision is made more proximal in the epididymis until motile sperm are obtained. As soon as motile sperm are found, sperms are drawn into the micropipette by a simple capillary action. This is the epididymal sperm aspiration technique. These are the comparison between different techniques and in microsurgical epididymal sperm aspiration. This procedure, the disadvantage is that it requires the anesthesia and microsurgical skills not indicated for non-obstructive azoospermia and percutaneous epididymal sperm aspiration. It can be done in local anesthesia, and complications include hematoma, pain, vascular injury to testis, and obstruction of the epididymis. In testicular sperm aspiration, no microsurgical skill required. And it can be done in local anesthesia, can be used for obstructive azoospermia, but the yields are poor and the immature or immotile testicular sperm poor results in non-obstructive azoospermia. Complications are the same as hematoma, pain, and vascular injury to the testis. Testicular sperm extraction, low complication rate if performed microsurgically. Preferred technique for non-obstructive azoospermia, but requires anesthesia and microsurgical skills. Vasography, the indication of vasography is azoospermia plus complete spermatogenesis with many mature spermatids on testicular biopsy plus at least one palpable vas. The relative indication of severe oligospermia with normal testis biopsy, high level of sperm-bound antibodies, which indicate unilateral, bilateral, or partial obstruction, low semen volume, and very poor sperm motility. This is the picture of vasography. Vasography can be performed only at the time of planned reconstruction. Always sample vessel fluid first to allow cryopreservation of motile sperm if found. Use indigo karma instead of methylene blue to confirm patency. Formal vasography with X-ray contrast is needed only to locate obstruction proximal to the internal inguinal ring. The vessel fluid appearance are very suggestive of the procedure. That if the vessel fluid appearance is copious, crystal clear, watery, and there is the most common findings are no sperm in the fluid. Vasostomy can be done, and if there is a cloudy, thin type of vessel fluid, usually sperms are present, and vasostomy are indicated. If the toothpaste like or water insoluble, copious, thick vessel fluid is appearing, then there is no sperm and vasoepididymostomy should be done. Scanty white thin fluid are there. There will be mostly no sperm and vasoepididymostomy should be done. If dry spermless was no granuloma at the vasectomy site, there will be no sperm and vasoepididymostomy should be done. If scanty fluid granuloma present at vasectomy site, Barbota's fluid reveals sperm and vasostomy should be done and sperm will find their way. Vasostomy, most popular technique is microsurgical multi-layered microdot technique. These are the incision marked. The above cross is the superficial inguinal ring, and the longitudinal incision should be given on the lateral side of the scrotum. The vas is held by the nerve clamp and should be cut on sharp 90-degree. There is a micro technique, 6 dot equally are on both sides. This is the one side complete, and this is the final picture. Crossed vasovasostomy. Crossover is indicated when a unilateral inguinal obstruction of the vas deferens associated with an atrophic testis on the contralateral side. A crossover vasovasostomy should be performed to connect a healthy testicle to the contralateral unobstructed vas. Or obstruction or aplasia of the inguinal vas or ejaculatory duct on one side and epididymal obstruction on the contralateral side, it is preferably to perform one anastomosis with a high probability of success than two operations with a much lower chances of success. This is to perform a to increase the tension-free anastomosis, and the one testicle is placed in opposite side. Vasoepididymostomy is indicated when the testis biopsy reveals complete spermatogenesis and scrotal exploration reveals the absence of sperm in the vessel lumen with no vessel and or ejaculatory duct obstruction. These can be done by the conventional fistula technique, microsurgical tubular anastomosis. These are of three kinds: end-to-end technique, end-to-side, and triangular interception technique. These are the pictures of microsurgically vasoepididymostomy. The comparison of the three techniques is in interception technique, a disadvantage is cannot assess tubular fluid for sperm before anastomosis setup. In end-to-side technique, virtually bloodless and difficult suture placement to a collapsed tubule. In end-to-end technique, difficult hemostasis or transected epidermis, difficult to identify the proper tubule for anastomosis, difficult outer layer closure, vessel blood supply from inferior epidermal artery is sacrificed. The anastomotic technique keys to success is like every other anastomosis, accurate mucosa to mucosa approximation, leak-proof anastomosis, tension-free anastomosis, good blood supply. Because the sperm is antigenic in nature and the anastomosis will be preserved by the sutures only. Post-operative care, moderate activity 1 week, refrain from the heavy exercise and sexual activity 3 weeks. Like semen examination will be done at 1 month and every 3 months in 1 year. Most patients have a sperm in their semen within 4 weeks, and they wear a scrotal supporter at all times, even when sleeping or for 6 weeks post-operatively. Thereafter, a scrotal supporter is worn during athletic activity until pregnancy is achieved. The transrectal ultrasound guided aspiration of the cystic or dilated ejaculator, the aspirate is examined microscopically. If motile sperm are found, they are cryopreserved. 2 to 3 ml of indiocarbon diluted with water-soluble radiographic contrast is stilled. If a radiograph confirmed a potentially resectable lesion, curate is performed without the need for prior vasography. If no sperm are found in the aspirator, a vasography is necessary. If no sperm are found in either vas, when the vasostomy is made and vasography reveals ejaculatory duct obstruction, abandon reconstruction and plan for future IVF and ICSI. Simultaneous vasoepididymostomy and curate have poor results. This is the picture of curate. The complications are reflux, epididymitis, and retrograde ejaculation. Electroejaculation can be induced in most of men, especially those with a high spinal cord injury with vibratory stimulus. The electroejaculation is indicated in men who do not respond to the vibratory stimulation. Postmortem sperm retrieval requires the patient to have given permission for sperm retrieval and use before death. The varicocelectomy is the most common performed operation for the treatment of male infertility. Varicocele found in approximately 15% of the general population and 35% of men with primary infertility and 75 to 81% of men with secondary infertility, associated with a progressive and duration-dependent decline in the testicular functions. These are the different techniques of the varicocelectomy: retroperitoneal, conventional inguinal, laparoscopic, radiographic, and microscopic inguinal or subinguinal technique. The best results are from the microscopical subinguinal technique. The most popular technique are inguinal and subinguinal. In prepubertal children and In solitary testes, with a less experienced microsurgical surgeon, inguinal techniques can be done. And in prior inguinal surgery, obesity, lax capacious external ring, high external ring, long cord with low-lying testes, with a very experienced surgeon, subinguinal techniques can be performed. The incision of the subinguinal technique 2 to 2.5 centimeter below the superficial inguinal ring. These are the picture of varicocelectomy. Uh, the other method is percutaneous embolization by the radiology department. Transverse sclerotherapy through femoral or internal jugular vein. Catheter is passed in the internal spermatic vein and balloon or coils are deployed. The complications are balloon deflation and migration, varicocele recurrence. Thank you.
A very good morning to all of you once again. So I will give a brief synopsis of the management of male infertility. In the meantime, if residents, faculty, or those who have joined us has any question or any comment to make, please let me know. So we all know the management of male infertility could be divided into medical and surgical management. So amongst the medical management, the most common and rewarding management is of hypogonadotrophic hypogonadism. If a patient comes with hypogonadotrophic hypogonadism, which could be due to hypothalamic or pituitary causes, then you need to start the patient on gonadotropies and treat the patient for at least 1.5 to 2 years. And almost 50% patients would have presence of sperms in the semen, those who had presented with azoospermia. So that's the most rewarding medical management. And the second important medical management is other hormonal management, like in hyperprolactinemia, and then some cases of thyroid disorders also. And the other important thing is MAGI. MAGI is male accessory gland infections. So many of these patients of accessory gland infections like seminal vesiculitis, epididymitis, bronchitis, prostatitis would respond to therapy of antibiotics and antioxidants. So they may improve, the oligoasthenoteratospermia may improve in these patients. And the third most important is the empirical therapy in patients with idiopathic oligoasthenoteratospermia. So because many of these patients could be due to various causes, stress, the reactive oxygen species, and all those, where we might have to give in these patients anti-estrogens and antioxidants. Another therapy is giving aromatase inhibitors. So if the ratio between testosterone and estradiol gets less than 10, then you need to give aromatase inhibitor in these patients, because that will help to increase the serum testosterone level and may help to improve the fertility. And when we talk about the surgical management, as I said, varicocele is the most common cause, surgical cause for male infertility, and varicocelectomy in the form of microsurgical subinguinal varicocelectomy is the treatment of choice, which has the least complications. The other important surgical management is cases of obstructive azoospermia. So we have already known about how to evaluate cases of azoospermia. So everybody doesn't need a routine testicular diagnostic biopsy. So diagnostic testicular biopsy has to be restricted. It has a role, but a limited role. So we can do, even if you want to do a diagnostic testicular biopsy, we can do FNAC, fine needle aspiration cytology, or if it is not possible, can do a NAB. NAB is a needle aspiration biopsy, percutaneous. So that is possible. Most of these patients of testicular biopsy will actually require multiple mapping testicular biopsy, where you need to have a semen preserving facility for cryopreservation, where most of these patients may require some kind of assisted reproductive technique. So these specimen and the sperms, they need to be cryopreserved for either later assisted reproductive technique in the form of ICSI, or they may be required, again, the patient may have to be, this biopsy may have to be taken for a fresh kind of IVF cycle or ICSI cycle. So that is important. Again, those patients who are diagnosed as case of obstructive azoospermia, you have to remember that 2/3 of cases are actually epidermovasal obstruction, where epidermovasal anastomosis would work. But rest of the patients may have either the whole tract, epidermis and the vas, fibrosed, and this is a kind of a generalized obstruction where vasoepidermal anastomosis would not help. The typical example is a tubercular obstruction where it will not help. And then there are cases where the obstruction is intratesticular in the rete testis. If the obstruction is in rete testis, again, vasoepidermal anastomosis will not help. So you have to be very clear about it. And the most popular technique and the most rewarding technique would be the intussusception technique with 2 sutures only. So either make a transverse or a longitudinal incision in the epidermal tubule and intussuscept that tubule into the vas. So that is the microsurgical operation, which has the maximum benefit. The other operation sometimes is done vasovasostomy, post vasectomy. Many of these patients would want children even after getting the vasectomy done. Then you can do a microsurgical vasovasostomy, and microsurgical approach is the best approach in vasovasostomy. And the other thing is about the surgical management of ejaculatory duct obstruction. So ejaculatory duct obstruction, if the patient presents with low semen volume, fructose negative, and an acidic pH, then these patients need to be evaluated, and the congenital bilateral absence of vas deferens should be excluded. And then you need to do a transrectal ultrasound in these patients. If the transrectal ultrasound shows a cystic dilatation of the ejaculatory duct and dilated seminal vesicles, then only you should proceed with treating ejaculatory duct obstruction. So as I said, aspirate, see the sperms, put some indigo-carmine or methylene dye, then go ahead with transurethral resection of the dilated cyst. And many of these patients might be helped, though there is a chance that later again they get obstructed. So try to treat them as early as possible. So once the ejaculatory duct is resected, then the patient has some amount of sperms, go ahead with either assisted reproductive technique in the form of IUI or IVF or ICSI. So I think that sums up probably all the management. And another thing is important from the urologist point of view is the sperm retrieval techniques. So you need to retrieve sperms for assisted reproductive technique, which has become very popular nowadays. So we need to know exactly how to retrieve the sperm. So in cases of obstructive azoospermia, you just need to do a PISA. PISA is a percutaneous epidermal sperm aspiration. And that usually helps because the epidermis is dilated, turgid, you would get some sperms. If it is a non-obstructive azoospermia, then you need to do either multiple mapping testicular biopsy or single seminiferous tubule technique that is called SST technique, or you may have to do a testicular sperm extraction by biopsy gun, or you have to do a microsurgical TESI, that is micro-TESI. That's the best approach and the ultimate approach to find the presence of sperms in non-obstructive azoospermia, where you bivalve the testis under the surgical microscope and try to see the fluffy kind of seminiferous tubules, like the juicy seminiferous tubules that can be seen under surgical microscope, and take those only tubules and try to see whether they have presence of sperms. So it's a kind of a lengthy process. It requires a lot of effort, may take 2 hours in the operation theater to see those seminiferous tubules which have sperms. So I think this sums up the surgical management of male infertility. Now we will go with the MCQs, right? So for the benefit of residents, this is question 11 is the first, okay? Which of the following venous structures are intentionally preserved during varicocelectomy? External spermatic veins, internal spermatic veins, gubernacular veins, basal veins, and cremastic veins. Yes. So very, very easy, right? Basal veins, right? You never kind of occlude the basal veins. You have to exclude the vas along with its vessels before you ligate these veins, right? So most of the other veins, some people would ligate the gubernacular veins also and cremastic veins also, along with the spermatic veins. Which of the following surgical sperm retrieval technique is inappropriate for clinical situation indicated? PISA for congenital absence of vas is a technique is inappropriate. This is all right. Congenital absence of vas, appropriate or inappropriate? Appropriate. PISA after failed vasoepidermostomy. Okay, yes. Electroejaculation in a man with post-retroperitoneal lymph node dissection for left testicular embryonal carcinoma. Yes. Microsurgical MESA for spermatogenic maturation arrest. Well, so how would you find, if there is a maturation arrest, you would not find mature sperms in the epididymal tubule. Tessie in a man with azoospermia from chemotherapy. You can't find. I think this should be MESA, right? MESA. Because once, if there are no sperms in the testis, how would you find it in epididymis, right? And the rest, you all know, are important. Electroejaculation, again, is a process where we have a Seeger's electroejaculator. So patients who present with anejaculation, right? So it could be either orgasmic or anorgasmic. Orgasmic anejaculation, which is due to mainly organic causes, there you would require some kind of machine to get the ejaculation. So many of these patients may not be helped by vibrator only. There you have to put a Seeger's electroejaculator, where a probe with electrodes is put on the rectum, which stimulates the prostatic plexus to stimulate the reflex where the patient ejaculates, right? So that is usually done in patients where there is an injury to the plexus, sacral plexus. Post-operative, post-pelvic surgery, injury, all these cases may require, particularly patients with spinal injuries, paraplegic patients, all patients may require electroejaculation. Yes? Kisme? Yes, both can happen. There could be retrograde ejaculation, there could be retrograde ejaculation is usually doesn't happen. Post RPLND patient mostly will have an ejaculation. Mostly. So if there is retrograde, you know how to diagnose a retrograde ejaculation. That I won't go into details, but post Seeger's electroejaculator therapy, the patient may not ejaculate antegrade. They may ejaculate retrograde. So in that case, you have to retrieve the semen or the sperms from the blood, right? So compared with other surgical options for varicocelectomy, the advantages of performing a subinguinal microsurgical varicocelectomy include all of the following except low rate of arterial injury, lower rate of postoperative hydrocele, lower rate of varicocele recurrence, fewer veins ligated, lower overall complication rate. So it is D, fewer veins ligated. No. So as you go more proximally towards the testis, in the subinguinal region, you will find more veins to ligate. And as you go more distally, like in the inguinal or the suprainguinal Paloma's approach or the laparoscopic approach, you ligate only one vein, main gonadal vein, right? Which maneuver should be avoided when bridging a large basal gap during vasovasostomy? mobilization of vas towards the external inguinal ring, dissection of the sheath of the convoluted vas deferens of the epididymis and allowing the testis to drop down upside down, separation of the chorda and corpus epididymis from the testis, mobilization of the vas deferens towards the internal inguinal ring, unraveling the convoluted vas deferens. So, what is the answer? During vasovasostomy. Unraveling of the convoluted vas deferens. Usually doesn't help. But mobilization of huh? What should be avoided? Unraveling the convoluted. So what the answer is unraveling?
Yes.
Okay. So you may unravel the convoluted vas deferens, but it is very difficult to do a vasovasostomy in a convoluted vas deferens. Right? So always remember that that could be one of the ways, though I do not agree much with it. Which of the following is a true regarding varicocele? Treatment in infertile men rarely results in improved semen parameters. Which is true. Okay. Severity of testicular insult is related to the size of the varicoceles. Severity of the testicular insult varicocele is duration dependent, independent. Okay. Because of the severity of testicular, repair of large varicocele is not warranted. Surgical treatment of subclinical results in greater improvement. So which is the answer? The answer is duration independent. It is duration dependent. So longer the duration of varicocele, the chance of infertility would be higher. So which of the following is true, he is saying, right? Which of the following is true? So treatment in infertile men rarely. So this is false. Severity of testicular is related to the size of varicocele. Size, yes, this is true. So B is true, right? B is true. So right. So thank you once again. If anybody has any question, please let me know. Can we go to the presentation? Yeah. So if anybody has any question, please let me know. Otherwise, we will wrap up the session. Dr. Adi, you want to say something? Okay. I don't think anybody has any question to make. So we would wrap up the session here. And thank you and have a good day. Where is the leaving? Leave. Okay.